Welcome to Endoscopy Now and today's virtual education program titled Master's Techniques in Biliary Cannulation and Sphincterotomy. This is the first of a four-part series called ERCP Voices of Experience, hosted and moderated by Dr. David Diehl. We hope that you will enjoy today's program and will dial in for the future episodes that will air in October, December, and February, and will cover various aspects of ERCP, including stone management and stenting. I'm Sandra Gormley, a Senior Product Manager at Olympus, and now it is my pleasure to introduce our host and moderator, Dr. David Diehl. Dr. Diehl is a professor of medicine and pathology at the Geisinger Commonwealth School of Medicine and the founder of the Division of Therapeutic Endoscopy at Geisinger Medical Center in Denville, Pennsylvania. He also created the Advanced Endoscopy Fellowship at Geisinger, which has been going on for 18 years. He was a GI Fellow at University of California, San Francisco, and ERCP Fellow at UCLA Medical Center. Dr. Diehl, thank you for joining us today and for hosting and moderating this program. The mic is yours.
Thanks, Sandra. I appreciate the invitation to host this program and this series of webinars. And it is my pleasure to introduce our first guest, who's someone I know very well, Dr. Douglas Adler. He's currently a professor of medicine, working in Denver now, was at the University of Utah for many, many years. He's a director of the Center for Advanced Therapeutic Endoscopy at Advent Porter Hospital with Peak GI. And as everyone probably knows, he's editor-in-chief of Gastrointestinal Endoscopy. And Doug and I love just talking about, we were thinking we could talk about ERCP for days and days. So we're going to have to rein it in, Doug, to keep it down to 45 minutes.
I thought we were booked for 9 hours. No? Did
Nope,
I get that wrong?
quite. So there's some disclaimers. And, the first thing, I was looking through an old slide deck of mine, and our learning objectives, we want to talk about the ductal anatomy and papillary architecture, learn the right techniques and select the right tools for different clinical scenarios, and touch on some challenges and complications of ERCP cannulation. So on this old slide deck, it's so important to use CO2 insufflation for ERCP. And this is an example of someone who had abdominal pain after the procedure. We're worried this person has post-ERCP pancreatitis, get a KUB and just see a bunch of gas in the small intestine. And when you look back, and the scope was feeding room air, not carbon dioxide. So my question, do you know anyone who still does ERCP without CO2 insufflation, Doug?
So it's so funny that you asked this because it's August and we have a relatively new advanced fellow, and he learned very quickly that not only do we turn the CO2 on every case, but he will conspicuously see me look over my left shoulder and see that the air is off.
Right.
And, every 20th or 30th ERCP, like as the scope is going down, the air is on. I don't know how that happens. Somebody hits it or it gets bumped. I don't know. So we always check it every single case. I don't know anybody in the U.S. Still using air. I mean, obviously it does require a CO2 tank and an exogenous CO2 pump. But I do suspect that some parts of the world may not be using that. But in the U.S., I think everybody has gone to CO2. I mean, it is pretty amazing what it does for you.
Oh, yeah. I mean, if I was working at a place that didn't have it, I would basically refuse to do ERCPs until they got it.
Oh, yeah. But just think how many years we did it with air. Ooh.
I know. And I also kind of like obsessively check the setting. And, I often have thought that should be like on a fighter plane. There should be like the ejection seat. There's a cover to it, so you're not going to hit it by accident.
Pull the 2 rings over your head. Or it should manually lock out when the CO2 goes on.
Yeah.
Although I'm not going to lie, sometimes if you really just need a little bit of extra distension during a particular maneuver, I will toggle the air on just for that maneuver to kind of give me a little extra boost of distension or wall tension, and then turn it off as soon as I don't need it. That's a good trick that a lot of people don't think to do.
You know, the next thing I want to bring up, and it's very fundamental, is, are you long wire or short wire?
So we are
you physician controlled wire? Do you have
right?
some
I was going to
experts?
say that's an interesting. The way you worded that is kind of funky. So we are all physician controlled wire. You and I are old enough that we trained before physician controlled Guidewire devices it really existed or were in widespread use. But you know, kind of once you take over that wire, and physician controlled Guidewire was really coming when I was an advanced fellow. Once you kind of take over that wire, it's really, really, really hard to give it up.
I agree. And I feel it's really important for fellows to train on physician controlled wire, because you may be in a place where maybe you don't have a great assistant and you just want to be the best person in the room to manipulate the wire.
The one thing I would say though to fellows is, and my fellows know this, like we don't let them have control of the wire for a little while because they're so busy in the beginning and they're cognitively saturated with the scope and the catheter or the tome that to throw the wire in, like they run out of cognitive room. So we typically sort of gradually give them control of the wire over the first month or two.
Yeah. And we're going to talk about the clever cut sphincterotome. I like the clever cut that has the separate channel for the wire, because then I can do the wire, the fellow can do the wire very, very easily. Whereas if you have a strippable wire, harder to control that. And, you know, we all are really rely on the Olympus scopes with a V-lock. So you can use short wires. There's very few situations anymore in the biliary tree that you need a long wire.
I think that's true in 2025. There's a few devices that only work with a long wire, but short of those, you can get by with a 260 wire or something similar. And the elevator, the V-lock, is pretty reliable. I mean, you can hold a wire very, very safely while you're doing all sorts of exchanges and maneuvers. And there's very, very little play in that wire unless somebody really tugs on it.
Right. And there's a little trick, and you probably know it, is sometimes the wire doesn't seem to be locking. If you open the elevator fully and close it fully again, more often than not, it'll solidly lock the wire at that point.
Right. Maybe it wasn't exactly in the groove where it needed to be. And that's true of both 2.5 and 3.5 wires. The V-lock will hold both.
Yeah. You know, the other fundamental question is, we do supine ERCP. And I know we all learn prone, and prone is kind of the standard way. But I always feel like if you're called to the OR, they're doing a laparoscopic procedure or even an open chole, and you need to go and do an ERCP, sometimes it's very hard or impossible to prone somebody. And if you're familiar with the angles, how to stand, where to position yourself supine, then it's never an away game. It's always a home game. So that's why
a good way to put it.
What's that? Yeah.
It's always a home game. That's good. I'm going to steal it.
So we essentially do all our ERCP.
Wow. Your anesthesia must love you.
They like it. I mean, if we wanted to prone them, they would insist on tubing them. Whereas if they're supine, we can do MAC. How about you? Are you still prone?
We're prone. We're prone, very, very heavily prone. We supine if they have an open abdomen, if they are very obese, and because there's obviously issues with ventilating or respiration in the prone position if you're a very, very large individual, obviously if they're pregnant, and in other situations. But I would say we are prone 95% of the time.
Okay.
And I will tell you too, that we intubate our ERCPs. So by and large, our ERCPs are intubated, which is also, it's very easy to prone them if they're on, if they're tubed on a vent.
Yeah. And there was a thing I always wanted to ask you. I don't think I've asked you this before, is as anyone ever reads a paper written by Doug Adler, the X-ray image is classic British backward. I call it backward. Maybe it's not backward. Maybe it's right. And I, that's how we used to do it. And many years ago, I switched to flipping it around, but why do you persist on the classic?
So let me answer one quick thing about prone versus supine. And I'm going to answer about the fluoro, because when I post pictures online on social media, people are always like, the first few times they see my post, they're like, what? So it's interesting because if you're doing ERCP supine, you're probably using MAC, right?
Often, not always. Sometimes we do them MAC too.
So it's interesting because the prone versus supine question is also, it's tightly related to the general versus MAC question. And we've written a couple of papers on this. You might even be on one of them, David. But if you look at ERCP outcomes, MAC versus general anesthesia, the ERCP outcomes are the same, exactly the same. Technical success, clinical success, adverse events. But if you look at cardiopulmonary adverse events, they are always higher with MAC. So just recognize that, intubating the patient and, putting them on a vent, it does buy you more, it does cost you time, right? You gotta pay the piper somehow. But if I had to have an ERCP, I would want to be intubated personally.
Yeah, I hear you. It's interesting. On a little side comment, I was in Winnipeg last fall and talking to the advanced endoscopists there, and it's very hard for them to get general anesthesia or even, propofol, almost impossible. They're still doing ERCPs, conscious sedation. Hard to believe.
Ooh. Yeah, that's how I did my first maybe 2,000 ERCPs. It is tough, like Fent and Versed and oh boy, that is tough.
The next avenue I want to talk about.
Wait, we got to talk about the flip.
Oh yeah. Oh, please.
So when I was an ERCP fellow at Mayo Rochester, that's how we did it. And that's just kind of how I learned it, and I got very, very comfortable. So you're doing an AP view. I'm doing a PA view.
Yeah.
There's one benefit to the way I do it over the way that most people do. And I've trained all my advanced fellows and over the years, and anybody I've taught ERCP, I've taught them my way, and they're all out there doing it. So we're a small minority. But if you do a PA view, like I'm doing, your directions are true. So the right side of the screen is the right side of the patient, is the right biliary tree, and the left side of the screen is the left side of the patient and the left biliary tree. So your directions are true. Whereas if you're doing an AP view, the right side of the screen is the left side of the patient. So you've made a 180-degree flip there. So you have to kind of account for that in the way you speak. Whereas if you do a PA view, your directions are always true.
Okay. The next thing I want to touch on is just anatomic landmarks. And there's this diagram, and I learned this from Dick Kozarek. He taught me this a long time ago, that there's this 11 o'clock, 5 o'clock relationship between the CBD orifice and the PD orifice. And, that rings true 99.9% of the time. So if I cannulated the P, I know where to look for the C, for example, and vice versa. And if I want to, at this point, just focus on that left image, this is just an ampulla, and I overlaid just this grid. The yellow is 11 and the blue is 5. And, if you're going for the C, you always want to go kind of up and to the left. And usually we're going for the C. And do you have any thoughts about that orientation?
So I think that the Dick Kozarek 11-5 thing is pretty true, although the P can wander about a little bit. I kind of feel like the pancreatic duct can often be in the sort of 1 to 5 o'clock corridor. But I think, if you're going to talk about the o'clock, and again, maybe you disagree with me on this, but I think that a lot of people, I can't tell you how many people get this o'clock thing fundamentally wrong. And I've had to disabuse a million people of this notion that 12 o'clock is 12 o'clock on the screen. Like they think like 12 o'clock on the Olympus monitor is 12 o'clock, and it's not. 12 o'clock is the intraduodenal portion of the duct, which often runs at an angle. That is 12. And then all of your other clock positions are based off of that. And I can't tell you how many times I've told that to people, and like just the blood drained out of their face as they realized that they thought it was 12 o'clock on the screen. So it's all relative to the intraduodenal portion. So
that's a good point.
I agree with you, but you have to just know where the clock is facing, basically.
Right. The other two fundamental points about orienting where to go are illustrated in these other pictures. Again, your point about the O clock is well taken, but the C is more kind of pointing to the left, and the P is more pointing to the right. And on the bottom right image, the C is there's more up, more upward angulation of
the Nike swoop.
Okay, fair enough. Whereas if you go more perpendicular, you're more likely to get the C.
Yeah. Well, and I think, it sounds so simple. And it takes hundreds of iterations to really, really learn that.
It is.
It shows you something about the way the human brain learns. You can't just tell somebody that once and they get it.
Exactly. And I know that you and I have looked at literally thousands of ampullae, and we can almost have a sixth sense of where the orifice is going to be.
Right. Very, very quick cannulations at our stage of the game. But, I remember when I was learning ERCP, and I published a paper on my learning curve, and I think I learned pretty quick, but it was very, very hard in the beginning. And I remember I would come home at night and I would watch videos on the couch of ERCP, like on these VHS tapes that the ASGE made. I remember my wife said to me one day, she was like, "Why does this take you a year to learn? Just put the catheter in that hole." And I was like, "Oh, like there's more to it." Like your brain just has to, you have to sort of like, there's the cognitive part and there's the technical part, and your brain has to learn how to make your hand move just the right way. And it takes hundreds of iterations. For the audience, both David and I have some experience flying single-engine aircraft. And I remember when I was learning to fly, I remember thinking that landing was like cannulation. Like you just have to do it again and again and again and again and again. And like, they can't tell you how to land the plane once and you get it. Like you have to land that plane over and over and over and over to begin to understand it.
Right. And I don't know about you. When I consent a patient for ERCP, I tell them, quote unquote, there's a 97%, success rate. There's always like, oh, the ampulla you can't find it's in a tick, or for whatever reason you just cannot cannulate that moment. And so I tell them, I list failure of cannulation as a possibility.
That's interesting. I don't know if we give, I don't actually do that specifically. I'm mostly talking about adverse events. I don't quote them success and failure rates. That's interesting though.
So here's an interesting case that I had.
Right, which you're never going to see again.
I've never seen it again. And I guess I suppose an ERCP fellowship would be a lot shorter if it was like this.
Right. Well, it's funny because like I'm sure you've done some endoscopy on pigs at some point in your career, David, and the pig biliary and pancreatic orifice are separate. They're totally separate. Like every cannulation in the pig is right where you want it to go, but we're not built like that.
Exactly. Just, there's all sorts of possible appearances. Bulging, we love bulging. Small, or you have to be careful how far you cut. The third picture is an adenoma. Right.
And is the papilla aberrantly located or aberrantly oriented?
Yeah, that happens. Here's a kind of an unusual anatomy that I can't remember the last one I saw. They're, obviously with PPIs and so forth, people are not having gastrectomies for ulcer disease. So we're seeing fewer and fewer of these. But I remember when I was a fellow, they were not that rare.
It's so funny that you were talking about this. So obviously Billroth 2s are mostly an obsolete surgery, except for a few circumstances. I have a particular interest in these, and I've kind of made it clear to all my referrings, like, hey, if you get a B2, I'll do it. And I really, really enjoy Billroth 2 ERCPs. I'm actually doing one tomorrow.
All right.
That's not a joke. I'm actually doing one tomorrow. But I've had a particular interest in them for many, many years. But even I, as somebody who, runs around yelling and screaming, I like doing Bill Roth 2s. It's 5 or 6 in a year, out of a very, very large number of ERCPs.
Yeah. I remember, so, these days, and I'm sure you do this, we start with a sphincterotome and a guide wire to cannulate.
Right. No more straight catheters.
What's that?
No more straight catheters.
No more straight catheters. It's hard to imagine that we use these fairly blunt catheters or these catheters with all sorts of different tips, but a wire is smaller than any catheter you can give me, and so catheters are fairly obsolete.
Yeah, I mean, and I think everyone has gone to sphincterotomy with some version of Guidewire cannulation.
Exactly.
I remember reading, when I was an advanced fellow, I think I was an advanced fellow in like 2003-ish, something like that. And it was a lot of injection, like sometimes we would try with the wire, but we were taught to, inject.
Yep.
We did a lot of injecting. And I remember reading Layla's paper in GIE in 2004, where he randomized to Guidewire cannulation versus traditional. And the Guidewire cannulation group had 0% pancreatitis. I remember bringing this to my attendings and they were like, that's a lie, impossible. and it wasn't a lie and it wasn't impossible. And I remember thinking like, oh, let's do this every case. I remember that specific paper by Layla really changed my practice.
Interesting. So my favorite Guidewire, and I don't know about you, but it's the VisiGlide by far. And there's a couple things I really like about it. So we generally start with an angle tip, and I love the one-to-one torqueability. So a lot of times I'll be spinning that wire, spinning it through the papilla, or spinning it to select an intrahepatic duct. That is one feature that I just can't find other wires match. And the other thing I really like, I like that it's 025. And I feel like 035 wires are okay. They're kind of like old history. It's like long guide wires. Yeah, we used to use them, but if I can have an 025 guide wire with the body of an 035 guide wire, that's what I want. Everything slides easier, more space. I like them. How about you?
I mean, you're preaching to the choir. So everybody who works with me knows that I'm, with very rare exceptions, all 025. We use a very large volume of VisiGlides in our practice. We have other wires too, but we use a large volume of VisiGlides. But that having been said, I almost exclusively use a straight Visi. That's really interesting.
Yeah.
The Visi is a little bit, you're kind of got one foot in both worlds because it's a 2.5 wire with essentially a 3.5 core. So you're kind of getting, as they say on Star Trek, the best of both worlds, right? So you can kind of mix it that way. But my Visis are all straight. I don't even know if we have angled Visis anymore in our lab.
Oh, that's amazing. I mean, but I occasionally use a straight, like for a minor papilla or something.
But it also shows you like there's a little bit of a voodoo factor. You know what I'm saying? Like you've done these so many times and you just intimately understand the properties of the wires you're familiar with. Like you can function so well with it. Whereas, my wires are a little bit different, like my wires are not the same wires you would pick exactly, but we're both functioning well with them because we're so it's like when you get up in the middle of the night to get a glass of water, you don't turn the light on. You walk right to the sink, you know exactly where everything is because you've done it a million times.
Yeah. I mean, doing the spinning maneuver, that like getting through a complex pancreatic duct, sometimes that's very useful.
Oh yeah. We like to knuckle, but same idea.
So, there's this, I like telling the fellows, get a view of the ampulla which is up the barrel rather than looking down. In fact, if it's looking down, I call that you're just about ready to fall out position.
Yeah, you're never going to get it.
And sometimes,
and if the fellow asks for full bow, never in a million years are they going to get it.
Okay. So, there's this other concept. I don't know if you utilize
These
this.
images are all backwards.
Well, look, the liver's on the right side, right?
Well, the right side of the patient.
And the right side, well, I mean, the radiograph is like like the patient's facing you, right?
Right. You're doing an AP.
Yeah. But long scope position versus short scope. Obviously, we're all often taught, go to short scope, everything maneuvers better, but sometimes long scope position gives you a better amplitude view. So you have to be ready to go from short to long and long to short. And I tell the fellows it's kind of like a dance step. You just have to learn it so you can do it like second nature. Do you find yourself sometimes going to long scope position?
More so when I was earlier in my career, I found going to the long helpful. Now, not as much, but we teach all the fellows. But I think you have to there's a couple of caveats to going to long scope. The first one is you have to remember to unlock your lateral wheel, right? Like I personally, when I make that transition from short to long, I don't leave the lateral locked. I want the scope to be looser so it does reorient, right? Because when you push in, I'll unlock the wheels and I'll push in and you'll feel the scope break in the stomach, as they say it. And that break term refers to the transition of the scope lying on first the lesser then the greater curve, right? When you're in long position, your scope shaft is on the greater curve.
Yeah.
And going long, and this is true whether you're cannulating or doing sphincterotomy in the long scope, it gives and it takes, right? As I always say, you got to pay the piper, right? So often long position will give you a better angle than you were getting in short position, but the trade-off is you have less maneuverability once you're in long position. So you're kind of married to that view in a way that you're not in short position where you have a lot more leeway. But especially I think during sphincterotomy too, if you don't get a great angle short, a lot of times going long or semi-long will correct your sphincterotomy angle instantly.
Absolutely. You know, so if something's not working, try something different. And persistence to a point is okay, but persistence past that point is you're actually losing ground. And ERCP is a time-sensitive procedure, right? You know, the first 15 minutes are different than if you're an hour and 15 minutes in. So
no
I
ERCP,
feel like go to plan B or plan C or plan D right away. And I will say, so, you know, different scope position, dual wire, which I'm going to talk about in a second, and needle knife, which we'll talk about in a minute. But the dual wire is a great technique, which very often gets you there. So let's say you only
almost always.
Yeah, you cannulate the P, get a wire in the P, get a second wire, and I have a video I'll show you. And I'm looking for, I call it a separation of the two wires. So the P's go one way and the C's going this way. If I see this separation early, I know I'm going in the right direction.
Yeah,
So
we use almost the exact same terminology.
Oh, good. So here's an example. Wire, there's a fizzy in the P, and then I'll put a second wire, and I'm see at that 11.5, right? So I'm aiming for the 11 o'clock side, the upper side.
And you're also looking for those wires to cross. Like those wires are crossing right there on the screen. That crossing is almost always synonymous with success.
Okay. And you know, it's a little tricky sometimes because the first wire sort of is binding you a little bit. You're not quite as free, but generally, if you try this is great thing to do right away.
And, you know, I think that if you get the wire in the PD more than once or twice, you know, like that's a sign like, okay, let's work with what we have, leave that wire in the PD, exchange out and get a second wire. The other benefit of the two wire that a lot of people don't talk about, but I think is a huge part of the reason of success is the PD wire, it orients the ampulla towards you. Like if that ampulla is rotated 10, 15, 20 degrees away eccentrically, that wire in the PD corrects that rotation. And all of a sudden, and maybe you didn't have this, like maybe the papilla was in a tick or something was funky, all of a sudden, you know, you have an en-face view for your guide wire attempt, right? So,
Exactly.
so I think that's a big part of why people succeed with the two wire is without even realizing it, they're correcting the angle that they're looking at the ampulla.
Right. It's straightening things. You
But
know,
I think, can I make one other point though? Like when you say try something different, I think people get sort of in this cognitive lock, right? Like the first 50 touches didn't work. Maybe the 51st, you know, like that's not going to get you anywhere. Like just the other day, I switched wires mid case and my fellow said, why did you do that? And I said, try something different. And like, boom, like we were in like 2 touches, you know, and like all these wires have very subtly different mechanical properties, you know, slightly different coating, slightly different hydrophilic soft tip length. Like just try something different. And, you know, if it means spending some more money and opening some more packages, so
absolutely.
It's better
So
than
be it.
telling the
Exactly.
patient you didn't get in.
That's right. Exactly. And I have to ask, because if I don't ask, someone's going to bring it up in the Q&A. You have a wire in the P. The dual wire worked great. You got into the C. Did a
I know where you're going.
Do you leave a pancreatic stent in that P, or does it depend?
Not typically, no.
Okay.
I mean, if I, so we published, oh boy, this is a long time ago. I'm trying to remember. I think Dharmendra Verma might have been first author on this paper. We published my single operator series of about 900 Guidewire cannulations. And in that paper, wire in the PD was, if it wasn't accompanied by injection, wire in the PD, which does not raise hydrostatic pressure, is not associated with post-ERCP pancreatitis. So if I just slip the wire in and I get in with a second wire very quickly, I don't typically place a PD stent, especially if I'm giving rectal indomethacin anyway.
Yeah, that's fair.
You?
I have to say, if I have a high-risk patient like a young female, I will absolutely put that stent in there, but I don't feel obligated to do so.
Yeah, and I'm not saying we don't do it sometimes, but routinely or every time a wire goes in the PD, no, I don't think you need to do that. And I don't think the data supports that either.
Well, this slide is here, but I want to, maybe this should be, we'll come to that later. Let's talk about biliary sphincterotomy. So one question is, how far do you take this sphincterotomy? And, this image shows, I feel like there's an intraduodenal mound, which is either round or kind of rugby ball shaped, football shaped.
Rugby balls.
Yeah. You can cut the whole intraduodenal mound. That would be like, that's how far you can take it. Therefore, if you have a very tiny papilla, you can't cut very far. If you have a bulging papilla, you can cut more. Do you have any landmarks that you keep in mind for how long to cut?
I mean, I think that there's a lot of things to take into account when you're thinking about how long to make the sphincterotomy. And I think many people, I just posted something on social media about this yesterday. I think a classic reason that people fail to extract a stone is they didn't go all the way. Because they're afraid. They're afraid of bleeding. They're especially afraid of a perforation or pancreatitis. And in general, I do think that your sphincterotomy, with very, very rare exceptions, should be complete, right? So you're going to take into account the shape of the ampulla, the diameter of the duct, the diameter of the stone, for example, that you're going after, or if you're planning on doing cholangioscopy, what's the relationship of the transverse fold to the ampullary orifice? Do you go to the transverse fold? Do you cut partially into it? Do you go completely through it and beyond? Everybody's different. But in general, I try to do a complete sphincterotomy. I think it's almost always better for the patient. It'll make your life easier in the rest of the case. And I think it really, really lowers the risk that, that sphincterotomy can scar down at a later date.
Yeah.
So I don't hesitate. The flip side of that is, if somebody sends me a patient that they've done a sphincterotomy on, and I don't think it was adequate, I don't hesitate to extend and complete that cut.
Yeah. I remember when I first started working here, I got a lot of referrals for, can't get the stone out, the balloon kept popping.
Right.
And there was these tiny little cuts. So
it's still true.
At the same time, I will say that sometimes you don't want to do a full cut. Maybe the person has a coagulopathy. Maybe there's a big tick and you don't want to cut too deep into the tick, or any number of reasons. So you can do a balloon sphincteroplasty, which we're going to talk about in a minute, which I think has helped a lot. This is just an example of post-sphincterotomy bleeding, which this was a case from a long time ago. This was when I was at Bellevue.
Oh, wow.
So I want to comment on sphincteroplasty again. So it's for cases you don't want to cut more. It's like large stones. And there's a really nice device, this one, the StoneMaster V. It's a combination sphincterotome and dilating balloon. It comes in two sizes, 8 to 12 and 12 to 18. I want to show you a nice video. This is that StoneMaster V. So you have that nice, kind of a clever cut type tome, which I love.
An insulated wire.
Yeah. And then you pick the balloon size based on the duct size. So if you have a large duct, you can dilate to 18 if you have an 18 millimeter duct. So this was they came out with the smaller one later. So for a few years we just only has the large one. But I will, you can inflate this to easily 15 millimeters or whatever very safely. And very rare to encounter any bleeding or anything from sphincteroplasty. Now, importantly, you have to do a sphincterotomy.
Yes, critically.
Critically.
Right. So the large U.S. trial, I think it's from 2004.
Look at this, Doug. Look right up the duck,
Yeah,
huh?
right. Hello. Right, like, but the large sphincteroplasty without sphincterotomy study was done at the University of Utah. I think Desario is the first author on that, and that study was stopped early because of
Yeah,
adverse events, including deaths. So the
exactly.
take-home message from that was sphincteroplasty with sphincterotomy, yes. Sphincteroplasty without sphincterotomy, no, at least in Western
I
population.
was going to say, not in the United States, but in Japan they do it, and without
Right,
much.
and it does appear to be different out in Asia, but in the West, cut.
It used to be, you don't hear about this much anymore. It's like preserving the sphincter. It used to be felt to be important. That's why people were doing sphincteroplasty without cutting. But there's long-term follow-up data showing that for several years people were worried if you have reflux of enteric contents in the bile duct, will it cause cancer of the bile duct? And like some sort of 15-year follow-up, no, it doesn't increase the risk. So
we did, I think Trey Folkers was first author on this paper. We looked at a very, very long-term study of people that underwent sphincterotomy. And there's two ways to look at that data, because we did see that there is some increased risk of pancreatic or biliary malignancy over the patient's lifetime. But I think it's very heavily skewed because of sample error, because who's getting a lot of ERCPs? People with PSC, people with chronic pancreatitis, right?
yeah.
So those are, I think that you're seeing more increase in those cancers because who gets ERCP? Not healthy people.
Right. Good point. So this is an important thing. Sometimes we'll get a referral. Someone's on Plavix and aspirin. They had a coronary stent put in a month ago, whatever, and now they're having a biliary problem. And what you can do is you can do a minimal papillotomy. So you cut not the whole, as far as the whole thing, you cut it 2-3 millimeters, you balloon the rest of it, you can get the stones out, and the risk of bleeding is quite low. We did a paper which was published in GIE with historical control, showing no increased risk of bleeding. And I always thought that, I don't think people have gotten this point. Like when I remember talking to people, what would you do in this situation? And some people were like, oh, just put a stent in for 5 months or something.
Right. Which is not wrong.
Another situation, like you have a cirrhotic patient, say with an INR of 2 or whatever, 2.5, you can also do the minimal papillotomy balloon sphincteroplasty technique. So listen, we got to talk about needle knife. We have 5 more minutes before the Q&A.
Okay.
And needle knife is so important. And I feel it's so important that fellows learn needle knife, because without needle knife, there's going to be a good percentage of cases that you're just going to fail. It's just how it is. And so
it's a great rescue tool.
Yep. So here's an example, a big bulgy ampulla. We love the bulgy ones because you cut and
you're going to be totally fine.
Yeah, it's like, you're drilling for oil,
in East Texas.
Exactly. Texas tea, we call it when we hit that. So they don't always go like this. I mean, where you one cut and you're in. That, if it's super bulgy or if there's a stone down there, yeah, that might work. But I have one other video I want to show you, which is the way I learned to do needle knife. But this is great. So when they're bulgy, stone disease, or if you have an impacted stone,
it's a chip shot.
It's a great case if people don't have a lot of experience doing needle knife. It's a great case to do needle knife on, because you're safe. I mean, you're basically cutting an onion on a chopping block, right?
Yeah, I mean, I remember for example, our last fellow last year, he had a couple of needle knives from impacted stones. And like, as soon as we would see it, I would just pull the tome out and I would be like, oh, let's open the needle knife. It's the perfect case for the fellow.
Exactly. So the next needle knife video is I want to
show the video, then I want to make a comment about needle knives.
Oh, sure thing. So this is, I call it the two cut. And this is, I learned this from, there's a very famous ERCP doc named Kees Hybritsa from Netherlands. And this is how he instructs people in doing it. You do one cut of the mucosa, and you like a long cut so you can see inside. You don't just make a small cut and probe. You make a long cut so you can see stuff. Because then what you do is you spread the tissue and you look for the duct inside. And that's
right, or that little spit of bile.
That makes all the difference. Well, so you can see that tubular structure. There's the duct. So your second cut is into that thing. And if you do this two-step, it works like 90% of the time, or plus 90 plus. On the other hand, if you do a little cut and probe around, I find that needle knife's a very visual thing. You're seeing where you're cutting. You're not just blindly probing. You're seeing a structure, cutting it, and then you can probe. So, you don't sometimes like there's the wire goes in there. So if it starts bleeding, the problem with bleeding is that you can't see anymore. I mean, so.
Right. Well, and the other thing too is, if it's not an impacted stone, if I get in with the needle knife, then I'll generally switch back to the tome and complete the cut with the tome.
Yeah, usually I do that too.
One point I just want to make about the needle knife, because again, you and I are grizzled veterans, right? But for a lot of people, the needle knife comes when they're scared. They're frustrated. They're scared. They're an hour behind. The nurse manager has poked her head in twice. Why are you guys so late? Right? I'm going to have to keep the staff overtime. Right? So the needle knife, you do have to be calm when you do it. And I always think about in Titanic, in 1997's James Cameron Titanic, when DiCaprio's character, Jack Dawson, is handcuffed, right? The ship is sinking, the water is rising, he's handcuffed to that pole. And his one true love, Rose DeWitt Bukater, played by Kate Winslet, comes down with a hatchet to cut the handcuffs and free him. He says to her, take a few practice swings before you come at me. And I remember thinking, like, yeah, that's just like needle knife, right? So like, you don't want to just start like cutting like you're Luke Skywalker with a lightsaber. Like, it's important to take a few practice swings without stepping on the pedal and see exactly where the tome is going to go as you move it through an arc. And that's really, really important, so that you're not surprised by the the needle knife's movement when you try to get in there.
Yep. And as a corollary to that, if you've been poking around for 45 minutes, things are edematous. This tissue is not going to split. You're not going to see inside. That is not. Yes. So, I feel like I don't want to do something. I don't want to persist long enough where I'm going to screw up my needle knife success. So right. I will go to needle knife sooner rather than later. So, but I guess the last.
One of the people who taught me ERCP was, it's fair to say, pretty impatient. Okay. and if we didn't get it like in a few touches, he would be like, open the needle knife. And I'd be like, do you want to try a little more? And he'd be like, open the needle knife. And I was like, okay. So like, it is, in general, the data shows that outcomes are better if you reach for it a little bit sooner. Whereas if you're poking away for an hour, you're going to have a tougher time, hands down.
Great. Doug, we're right on time with the Q&A. So let me read some of them to you. The first one, it's greetings from Malaysia. It's 7 a.m. Some small GI units in Malaysia unfortunately still use air for ERCP. Major tertiary hospitals will use CO2. And in Malaysia, we all use long wire system handled by the GI system.
Interesting.
Yeah.
It's like ERCP 1998.
Right.
Right. No, seriously.
Here's another question. Thank you for your time and knowledge. How do you manage the exposure to radiation?
So do you want to answer that, or do you want me to?
You.
So everybody knows that some people in the ERCP are lead foots. I'm a light foot, like I'm like tap, tap, tap. And for example, on our fluoro units, you can toggle the rate way down. So I toggle the rate down as low as it can go. There's really no reason to run fluoro and ERCP at 24 frames per second. That's a crazy amount of exposure, both for the patient and for you. I urge everyone to get leaded eyewear. Like if you are doing ERCP, you must have leaded eyewear. I mean, you will get cataracts. God forbid you can get other troubles. So I'm super light on it. We use external shields between us and the C-arm, leaded eyewear, and toggle the machine way down. Like, when I trained, we just ran it at 24 frames a second. And that was because I didn't have any say in how the machine was set up. But as soon as I got out, I learned how to operate the C-arm in a lot of detail. And one of the first things I learned to do was toggle that C-arm rate down. And I started going lower and lower and lower. And I learned it didn't affect my success rate at all. So I have the machine set on the lowest frame rate.
Okay. I will say this is an advantage of doing patients supine because my back is to the patient.
Oh, that's true.
But when I saw an eye specialist a few years ago, I thought for sure I'd have cataracts with all the ERCPs I did, but I did not.
Pretty good. Yeah, but the flip side of that is I know more than a few people who got cataracts, in their late 40s, early 50s, who did a lot of ERCP. So that was hard to ignore. So I don't have cataracts as of my last eye exam, but I have always worn leaded eyewear. And leaded eyewear is not comfortable, and it is most definitely not stylish, but I wear leaded eyewear every case.
Okay. There's a lot of great questions. How long do you struggle before switching to needle knife? So, I'll start the answer and you can give your answer too. It's short. Sometimes again, just from, we have a feel for, I think I can get this papilla eventually, but I do not want to cause either edema or bleeding or something where my needle knife is not going to work. So it's a fine line. So, maybe 10 minutes, I would say, something like that.
Yeah, I probably hang in there longer. Like I'll hang in there with wires and switch tones and play around a little bit. There was a nice study by Gavin Harewood years ago that showed that as your experience with needle knife rose, your time to cannulation fell and your success rate rose, but adverse events stayed high, even in the hands of experts. So
Right.
recognize that, when you reach for that, you are accepting a higher level of risk. So I will hang in there longer, for example, hoping to get into the PD so I can then quickly do a 2-wire cannulation. But that having been said, I do needle knife if I need to.
Yeah, I'll probably do dual wire first.
And almost every time you do the needle knife when you get in, you think, God, I should have done this faster. Right?
There are more recent data shows that the needle knife does not confer pancreatitis risk. It's probably the poking around that does.
Probably. Yeah. No pokey. No pokey.
There was a question, I believe, if I'm reading it right, it's the transpancreatic sphincterotomy. So the wire's in the P, you can't get into the C. Do you do transpancreatic? And I have to say, I do not. I know the data is good supporting it, but it's a regular freehand needle knife is, again, I'll do dual wire first, but I have more faith in my needle knife than a transpanc, because a lot of times when I've did the transpanc, I'm not cutting into the duct. It's not like I've cut through the P into the C. It doesn't often work that way. Do you do the transpancreatic?
Not routinely, no. It's certainly not high on my list. That having been said, the data for it is good, and I do know a single-digit number of people who swear by it. Like if they get that wire in, they're doing transpancreatic cutting all the time. I don't know if I would want that. If I was on that table, I don't know if I would want someone to do that to me right off the bat. Maybe hold that in reserve if other things fail. But I know some people whose threshold to do it is very low.
Yeah. There was a comment question. Would you ever consider placing a hemoclip to suspend a downward facing ampulla to a better position? Or if, overhang fold or something of the sort? What do you clip much?
So I've done it a single digit number of times and it's worked almost every time. I think I posted 2 cases of that on social media in the last 12 months. One was a papilla that was in a tick that was facing completely away from us. Like literally it was pointing up into the tick away from us. And we were able to rotate the ampulla 180 degrees. And then once last year, we had a patient who had just a very large redundant draping fold that every time we would lift it up, it would fall, lift, fall, lift, fall. You had like 4 or 5 seconds of view before the fold completely obscured the face of the ampulla. And we clipped that one up too. And I've posted both of those on social media, so they're not hard to find. That having been said, you rarely need to do it, but
Yeah.
you know, if that thought kind of crosses your prefrontal cortex, it's not a bad idea to consider because there's very little downside to it. Like if the
Right.
clip doesn't help you, it's not going to put the patient at any risk.
There was a report on underwater cannulation. I thought that was interesting to get better exposure.
And underwater cannulation is going to favor you more than it's going to favor me. And a lot of times, like in the 5 or 7 minutes it takes you to, switch devices, sweep out the stone or basket out the stone, or, the bleeding stops on its own. So like I won't typically stop the case to treat the bleeding unless it's obscuring my vision or affecting the patient. A lot of times low level bleeding, you can just work right through. Like I've seen people literally panic over low level bleeding, and they pull the wire and they're like reaching for their devices, and then all of a sudden they've given up their access, and then like they kind of forget, like, why are we here? Like, you're there to take the stone out, get the stone out, and then worry about the bleeding if you have to.
Yeah. Someone made a comment. Can you both comment about cases when a wire created a submucosal tract,
Very
like a
good
false
question.
tract?
Yes, very
And
good question.
so, let me respond. We see this from time to time. Um, I have not, fortunately, have not had any bad effects from just a guide wire being, making a false tract. If you're pushing a catheter through, it's kind of a different story because now you're making a hole. But with a wire, haven't had an issue. How about you?
Well, there's a couple of points, and this comes from the person who uses a lot of 2.5 wires. I do believe that 2.5 wires are slightly higher risk to make a false track. And I think that sometimes the false track can become dominant, and you will just find yourself going in there again and again and again. And if you inject in the false track, that is often the kiss of death, because then you've really, really altered the sort of local anatomy. Now, you can overcome that with careful manipulation or changing catheters or changing wires. Sometimes you have to needle knife to relieve the sort of submucosal bleb that you make if you inject in the false track too. I'm very careful not to create false tracks, but does it happen to me? Sure, sometimes.
Yeah.
And sometimes it can really stymie you, right? And you have literally no one to blame but yourself, because you're the one who made the false track that you keep going into now, and it can be very frustrating.
There was a question about needle knife. It was, what cutting direction is more recommended, bottom up or top down? And it kind of goes to the difference between so-called fistulotomy and needle knife papillotomy. And the
Right.
only difference is with a regular needle knife, you're starting at the orifice, and with fistulotomy, you're starting a couple millimeters above. And personally, again, I believe that the pancreatitis risk with needle knife is from poking around for 25 minutes beforehand.
Or
So
longer.
I like starting at the orifice because I know the duct is there. And if I start there, then I've oriented from the start for the duct. Other
And
people, I think if you have a big bulgy ampulla, probably doesn't matter where you start. How about you?
I certainly, having done a lot of both, I generally start at the orifice, because then at least your starting point is correct. And sometimes people get turned around, especially if things are swollen, and you could be oriented obliquely to the duct or at a funky angle, and you may not realize it. Whereas if you start at the orifice, you're starting in the right place. You may meander to the wrong place. That's another story entirely, but you're starting in the right place.
There was a nice video GIE submission. I think it was this month. It was from the group at University of Kentucky. They talked about palpating the ampulla, where you can sort of see where the duct is. I thought it was, and they have a few cases, and I recommend everyone look at that because it was a nice way to sort of suss out the ampulla.
On the modern the surgeons are all doing everything robotically now. I mean, obviously we are not, but the modern robots have haptic back feel, so they can get a feel of how stiff or soft something is through the robot. So we obviously don't have that, but you're basically describing the same thing, and sort of palpate the ampulla with the tip of the catheter, and you can kind of get a sense of where the duct is and maybe where it isn't.
Yeah. Dr. Adler, you stated that the wire in the PD is not associated with pancreatitis. What about a very deep wire or multiple passes?
Not in my experience.
Yeah, I have a couple comments. One is you have to be careful about perforating a side branch. Sometimes the wire looks like it's going in the direction of the P, but it's actually going through a side branch. And this happened to me more earlier until I kind of developed an awareness of this. So you don't always need to inject contrast to prove you're in the pancreatic duct, for example. Usually the wire goes easily.
Right.
But if it doesn't go easily or the wire has a little bend in it or something, I think it's better to put a little contrast in. You may be dealing with an ANSA loop that you need like a torqueable wire to get it through there, or maybe you can't even get through. So I'm not opposed to putting a little contrast in. I think that's kind of overstated now.
And I think sometimes even just like 1/10 of a cc is all you need to see, am I in the right place or am I in the wrong place? But a really important caveat, don't have your nurse do that. Like, if I'm not sure where I am, the nurse knows I'm going to reach over and I'm going to be the one to do that injection, because I can inject a tiny little bit of dye and take my hand off that plunger on that syringe immediately as soon as I see that I'm, for example, in the bad place.
This is an interesting question. With sphincteroplasty, do you try to push a stone proximally before dilating? And do you ever need to go more than 10 millimeters? And let me start that one. I don't worry so much. Let's say there's a stone distally. I don't worry so much about, oh, I'm going to push against a stone and that stone's going to damage the duct. I've not seen that. So I'll just bridge the papilla and dilate. And I will dilate. And the important thing is you match the balloon to the duct size. So if your duct is 8, use an 8 millimeter balloon. If it's 10, use a 10. If it's 15, arguably you can use 15. So you don't have a problem with the stone being there.
No, and I think the balloon usually, two objects can't occupy the same space, right? People are worried like, oh my God, I'm going to crush that stone into the wall. It doesn't usually work that way. And the balloon just sort of like shoots the stone up out of your way. It is amazing. Like sometimes you'll struggle to pull a stone out with a balloon or a basket, and then you do that balloon sphincteroplasty, and then it's just boop. Oh, there it is. Case is over.
Yeah, exactly.
And then you're just sort of like looking up the duct.
Yeah. It's like an Indiana Jones scene of the ball.
Right, exactly.
I had to throw in a movie reference.
There you go.
You're the movie guy, though.
I'll try.
There's a question from Ukraine, so I have to include that. Good evening. I'm from Ukraine.
Wow.
I want to ask you about balloon plasty. What pressure do you use, and is it safe for the ampulla? So the balloon, there's pressures recommended depending on the size of the balloon. So you just use that stated pressure for the balloon. And as long as you pick the right balloon size for the duct, I find it very safe. I think I use it a lot for many, many stone cases. And I think one time I had a bleed. I think there might have been kind of a very fibrotic stricture distally. And when the balloon sort of cracked it and it bled, it did eventually stop.
And sometimes when you inflate the balloon, like when you deflate the balloon, you'll see a little blood, but it's usually not clinically important at all.
Right. And I have seen, not my case, an outside case of a perforation from a balloon that was selected too large for the duct. Although I think that's also uncommon.
Right.
Any other comments about ampullae and diverticuli?
I would say fear not. I think a lot of people are afraid to cut. Often cannulation in the diverticulum is actually very, very easy because, you can see almost like skeletonized or naked. You can see the intraduodenal portion of the common bile duct very, very clearly. It's telling you, go here. Like this is exactly the orientation. But I think that cutting in the tick, you can often go much further than you think. And I think a lot of people are very, very afraid, and they've somehow imbued or imbibed along the way that that's a really dangerous thing to do. And I don't know if that's true at all. And I have done some extremely large cuts and ticks for many, many years. And I don't see it associated with adverse events as long as I'm tailoring it to the size of the duct and the size of the stone, for example, just like I would in anybody else. So I would say fear not to do good. Like if it needs a big cut and it's appropriate, it's not wrong to do it.
You know, there was a live course, and Greg Haber, who is like, he's one of the deans of ERCP in my mind. He was doing a sphincterotomy and a tick, and he goes, you know, you got to be careful about cutting too far because sometimes they bleed. And he cut that 1 more millimeter, and the thing started bleeding like crazy. It was so amusing.
Always
I
the
never
last
forgot that.
millimeter. It's always the
So,
last millimeter
so
because then you stop.
I've like, okay, so I'll cut as much as I feel comfortable. I'll stretch the rest of it, and that usually works.
But the flip side is, just to stay on bleeding for a second, David, you know, sometimes if you start to see a bleed, I'll keep cutting, right? Because you've cut that vessel part way. And if you go all the way through it, you can cauterize both sides and seal it. So sometimes, you know, people see that little bit of blood and they panic, but very often the answer is keep going.
That's true. That's true.
Especially if you're early in the cut.
The other thing about ticks that I've noticed is, again, the meter's running even faster than if there's no tick. And if sometimes over time with the air you're insufflating, the papilla can disappear. So if you get a wire in the P, that tends to hold the papilla out of the tick, and then you can do a dual wire. So a wire in the P is better than nothing and nowhere, right?
Oh, yeah. A wire in the P is gold, right? You could put a PD stent in, you could do 2-wire, you could rotate the ampulla. You know, it is worth just commenting. I know we're here talking about ERCP, but it is worth commenting that, you know, we do live in a different era now where if you really, really, really exhaust everything, you could always do your own rendezvous. You could throw a wire down yourself from the bulb with EUS. You could do an EUS guided colodocoduodenotomy. Like, you know, we have all these tools in our lab now. So I think sometimes people forget that, you know, they don't have to call IR. They could throw their own wire if they need to. And that almost always results in success.
Yeah. Maybe just a couple more and then we'll stop. But when someone had a question about this 2-step pre-cut. And so the question was, are you cutting deeper with the second cut? Sort of, you are. You are cutting. The first cut is the mucosa, and you really want to see the mucosa split open so you can see what's inside. And more often than not, you can see the duct in there. Not always, but often you'll see a tubular structure that's in there. And the second cut is that. So it is deeper. Same direction. Again, I feel strongly that you want to do a longer cut to start so you can see what's inside. A small cut and a probe, probably not going to work.
Yeah. I mean, at that point, you're committed, right? You just you know, I will often go in layers, right? And just sort of tease things apart. And then when I see that little spit of bile or a little opening to the duct, you just throw your wire right up. And like I said, I'll finish the cut, unless it's an impacted stone, I'll finish the cut with the tome.
Okay. Last question. There's a lot of great questions. Do you routinely use glucagon?
Virtually never.
Wow.
Like in a whole year, maybe once or twice.
My God, that's amazing.
Never. I think that it does help, but I just don't find that I need it.
We use it, you know, if I start to see motility, I'll break it out. I usually give a 0.5 milligram to start and then 1/4 milligram increments. It may be that if I think you're doing most of your ERCPs, you might have fellows sometimes.
Yeah, no, we have advanced fellows for every case.
Wow. I mean, if I had to estimate how often I'm giving gluc, I don't know, 1 out of 4 easily.
Okay.
Maybe more. So
the nice thing about the gluc, though, if you do use it, you know, you don't want to like spend it all in one place. Like it comes as 1 milligram and 1 cc when it's reconstituting. That's 4 doses.
That's right.
Give a 1/4 of that milligram. So, and if you give the whole milligram, it lasts just as long as if you give the 1/4 milligram. So recognize that, you know, if you're opening that bottle, you may need a couple of doses to get where you want to go.
I will say my first dose is a 1/2. I maybe not for a good reason.
Your loading dose.
Yeah, but you think you can start with a 1/4.
I mean, I always give a 1/4 if I need it. So okay. I will tell you, earlier in my career, I used it much more, and I just somewhere along the way just kind of stopped asking for it. Like I think last year, maybe once or twice.
Okay. So, Doug, thank you so much. This has been fun. As I thought, we had a lively discussion about various aspects.
Can I just say one thing?
Yeah.
This stuff is hard. Like the whole reason that David and I are here talking about this is, cannulation is tough. Like it's tough today. It was tough 20 years ago. I recently had the chance to time travel to DDW in 2125. And I got to see this syllabus, and there's going to be talks at DDW in 2125 on cannulation. Like this topic is never going to go away. By the way, DDW 2125 is going to be on Mars, so you can make your reservations for the hotel now. But just so you know, like this will always be like the interest in ERCP remains so high, and people are always going to have to learn how to cannulate and cut that sphincter.
Can I rent a Tesla on Mars, do you think?
Rob, I think at that point, Mars is going to be renamed Planet Musk, but that's another.
Okay. All right, Doug. Very
Dr.
good.
Diehl, Dr. Adler, thank you so much for the fantastic, engaging, insightful discussion. Great presentation. Thank you very much for joining us tonight. Enjoy the evening.
Thank you, guys. Thank you, David.
Thank you, Doug. Bye.